Okay. Ooh. Um, we're going to get started just for the sake of time. And as people trickle in, we can sort of ask if they have additional questions. We're going to go till 12:40, and then you guys will all get together. We'll walk you over to the endoscopy lab for the hands-on session. This is obviously very informal. We're all eating. It's meant to give you a chance to ask any questions sort of about how to get into advanced fellowship if you're not in it, or your first job afterwards. We have a lot of our faculty up here who do a range of different things and are at multiple different institutions. So I'll just start off and sort of have some of the younger faculty on the end just quickly go through their experience of finding a job, tell us what they're doing now, and sort of their 1 or 2 top tips while Paul's mouth is full of food for finding that job.
I guess I can start, Anna, as Paul's eating. But I think for me, the most important thing was having a institutional investment in my research career. So having that protected time. So I started off with 40% research protection. And so that was super important to me just because I wanted to give it a go in terms of going to academic lifestyle with an advanced endoscopy. But there's so many kind of different factors at play. At Ohio State, I specifically chose that program because they're pancreas centered, and I really want to focus on chronic pancreatitis and pancreatitis related endotherapy. So that was definitely a big motivating factor. But another huge thing is going to be the people you work with. I would have loved to stay at Colorado, to be frank, just because they have such amazing personalities and they're such a good team in terms of advanced endoscopy. And I think that's where it gets really tricky with advanced endoscopy, because a lot of programs have one big name that kind of runs the show. And you kind of have to be, within that hierarchy. So you have to be kind of mindful of that. But if you can find a team-centered approach, that's always beneficial, especially as a junior faculty, because it's easy at other places for you to just be tasked with doing the things that nobody else wants to do. So being mindful of that. Yeah, but again, for me, it was all about getting protected time, making sure that I would be well supported in terms of a research infrastructure with, for example, research coordinator support as well, and then being in a pipeline for research studies. So I have access to the Chronic Pancreatitis Consortium, which is the NIH U01 consortium. So involved in several R01s through that consortium. So that's been a real blessing for me.
I'm Paul Leonore. I'm from, I was an interventional fellow here a couple years ago, and I'm now at Loma Linda in Southern California. For me, for the job search, location was very important. We have 2 little ones, so we wanted to go back to Southern California. But just as important as that is probably just being in an academic setting where we have access to doing all these, the most advanced interventional therapeutics that we have on the market. So basically, I wanted to be somewhere where the training that I did would be put to good use with the appropriate infrastructure, the access to all the devices coming out, and the appropriate IR and surgical backup. And then for me, teaching is also, something very important. I like working with fellows and, imparting whatever knowledge that was imparted on me up onto, future generations. So I think just being at a tertiary academic center was most important for me.
Hi, I'm Natalie Cosgrove. I was at Washington University in St. Louis, and I'm in Advent Health Orlando. Shout out to our fellows that are here. So I think there's so many different factors when picking a fellowship and a job. And I think one of the most important things that I had to learn when I was looking for both is you can't weigh all those factors equally or you'll drive yourself insane. So you have to pick the most important things for you. And that might be needing to be by family, needing a certain research infrastructure. If you want to do a specific specialty like endobariatrics, are you going to a center that can support that and has the infrastructure? So pick the things that are really important to you that are on your must-have list, make a must-have list, and then an ideally would have list. And then it becomes much more clear when you're kind of comparing fellowship programs and careers. The other thing I'll say is always ask the centers directly if they're hiring. I would ask kind of colleagues or people I knew, like, hey, do you know if this place is hiring? And they'd say, no, 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 I'm friends with this person, they're not hiring. And I'd email them directly and they'd say, yeah, actually, we are hiring. So always talk to the centers directly if you're interested in applying somewhere.
Yeah, to reiterate a little bit about what's been said, but maybe frame this how I encourage any trainee to think about this. I think so if we're just talking about therapeutic endoscopy, I think the field is splitting into or physicians or have different areas of concentration. You have resectionists, some of which are up here on the stage. You have people who are pancreaticobiliary specialized. You have folks who maybe have an area of concentration more in Barrett's and ablation and then there's things like endobariatrics. So I think one of the first steps is to figure out where your passion is within interventional endoscopy. Some of that comes through your research experiences. Some of that is really just trying to make an educated decision, which I think many of you are here to do that today. Because that can dictate a lot about what type of career you can have, at least at this point. Some of those things have good representation in both community and academic practice. Some of those things you're not going to be able to do in community practice at all, at least at this point. So I think that's the first thing you have to ask yourself. And flowing from that, and probably an equally important question, do you want to work in community private practice, or do you have passions for a lot of the things that are part and parcel with being an academic gastroenterologist, interventional endoscopist, which is teaching and research. And it doesn't have to be both of those things. It could be leaning one way or the other. I would use that as the first step for your decision. Whenever you're engaging or applying for advanced fellowships, I think it's important, of course, to see if they're hiring where you're applying, because that, statistically speaking, is the most likely place where you'll have your first job. But I think it's very fair to ask people what their process is for placing their fellows elsewhere. You know, our institution, and this was done for me at Wash U. Steve did this for me, and I'm sure the team there did that for you at Wash U. Is, you know, they sat down with me at somewhere around August, September. What places are you interested in working at? What are you interested in doing? Give us the short list. We're happy to reach out with emails and phone calls and be an advocate for you and help you find that job, because you know, certain jobs just aren't advertised in the back of GIE and the Red Journal, or they're not going to be the jobs that, you know, we all get the emails and the phone calls about. So I think that's another thing that'll be helpful when you're considering taking that next step in your career, because you don't want to take a square peg and try and fit it in a round hole. You know, you're interested in being a resectionist and doing a lot of this high level stuff like EST and poem, but there's going to be different levels of barriers to doing that sort of thing in practice versus an academic setting. So I think that's something to think about. I'll stop talking. I did a lot of talking.
Hello, everybody. I think I am the black sheep here. First of all, I'm from Europe. Second, I'm a surgeon. Are there anyone else here who is a surgeon? No. I think the former speakers has pretty much said it all, but I think that passion is a strong factor. Also, for me, it was whether or not I should go into a more academic career. And if that is the case, then definitely you should go to a place where, if you have some passion for some parts of the body or organs or procedures, I mean, it's very good if that place you go to are good at that. For me, I ended up early in my career at the Karolinska Hospital in Stockholm. And I have been fortunate to been focusing a lot of endoscopy in the pancreas, which is a little bit off. But together with my other fellow surgeons, gastroenterologists, radiologists, pathologists, I think we created a pretty strong pancreatic center in Europe. I think, yeah. So passion and what you want to do, I think that's very important, how you make your decision.
All right. So That was great getting a different perspective from, all the different panelists at different stages of their career in different locations. So I think Dr. Wani is now going to walk around in case anyone has any questions, and we can take some of those questions as well. Yes, looks like that crowd there has a question for us.
I was going to pick on you, Eric. Yeah, thank you.
Do any of you have experience at safety net hospitals in doing interventional endoscopy?
So the question is, do we have anyone here has experience in working, doing interventional endoscopy in a safety net hospital, right?
I go to a county hospital out in Riverside once a week to do interventional procedures for them. I would say it's different. The resources are a little bit more limited, but obviously it's a great patient population to work with. In a way, it's rewarding in a different sense. But I think for some of the more interventional things, we still would prefer them even just to our main university hospital. I think it's similar here too. There's Denver Health for some of the stuff that they don't do there. They would transfer them over here to the main university campus. So there's definitely a need in certain safety net hospitals, but the range of what you can do might be limited depending on where you are.
Hello, my name is John Weiland. I'm a third-year fellow at UPMC. Are there other things besides salary and protected time, if that's interesting to you, that you should negotiate in your salary, in your contract?
I can start. I think one thing to consider is how many sites that institution may have. So how much time are you going to be at the main campus? If there are multiple satellites, it's easy to be in a position where you're promised a lot of time at the main site, but ultimately you end up 90% of your time elsewhere. So I think getting that in writing is important. Also, if you're taking an interventional job, how much general GI endoscopy are you doing? Both sort of outpatient scoping and then inpatient coverage. Is your call only going to be therapeutics, and are you only doing therapeutic procedures? I think that's really important too. And then protected time. I think you may have mentioned that, but what is the structure for that? What if you were to become interested in research? What sort of protected plan can you get? I think those are three pretty important things to focus on.
I would add to that too, it's important to ask about and possibly get in writing your support, or you can have a nurse, or you can have admin, who handles your patient calls, who helps with the pathology, who helps with scheduling. You want to make sure you're not doing a lot of that work kind of by yourself and that you have the right support. Also, equipment wise, it's important to think about if you want to do like endobariatrics, for example, do they have suturing? Do they have the scope to do suturing? Do you want to do interventional EUS? Do they have EUS equipment? So making sure that they have all the big ticket items that you would need equipment wise.
So I'll just make a comment that, there's no data for this, but what you hear that people are unhappy or get unhappy with their first job or their job, not so much necessarily because of the salary. It's all these other things that people complain about more than the salary side. So I think looking at these other things is actually more important than just the financial side of it.
I'll just make one more comment about this. In addition to everything that's been said, when you choose that first job, you want to also ensure that the practice that you're going to join allows you to do the kind of procedures that you're interested in. It makes no sense to join a group where they don't have room for an endoscopist to do more ERCPs, or if they're going to be protective of the case volume for interventional EUS or Barrett's, or if that practice is saturated with endoscopists for that specific procedure, and if you're interested in it, then that's a recipe for failure.
I was going to add to quickly fluoro time. If you want to do ERCP and need to do fluoroscopy, how many days a week are going to be allocated to that fluoro room? If you're in a non-fluoro room, obviously you're going to be limited as far as being able to do those types of procedures.
Good afternoon, everybody. I'm one of the advanced GI. My name is Muhammad. I'm one of the advanced GI fellows in New Jersey. I'm kind of in the same boat, kind of looking for the job at this moment. So a follow-up question, if your own institution is not hiring for an academic position, at an individual level as a fellow, what are the things that you can do to kind of reach out to other academic institutions, trying to find a spot which is probably not going to get listed online?
Sure, I have the microphone, so I'll take it. So if I'm hearing the question right, if your institution where you're just finishing your training does not have an opening for the kind of job that you're looking for, how can you look in other places when it's not really advertised? Is that the question? So if this is an academic setting that you're looking for, then I think word of mouth is probably the good way to do it. And you can talk to your mentors, and they might be able to connect you with people that they know, and that's how it might work out, which is how most often these academic jobs will go. Very few will be advertised formally. They may need to advertise it formally at some point to actually hire someone, but before that, this is how it's likely to happen. So as I tell all fellows, be nice to everyone. You never know when you'll need to do what with someone. So be nice, and somewhere someone will connect with you.
Yeah, don't be afraid to solicit that help too. You have a program director, I'm sure, for the advanced fellowship or people you're working with there. I mean, make a sit down meeting, not kind of off the cuff, in between cannulating and pulling stones out of the bile duct to talk about this. But make time, sit down with them, 30, 60 minutes carved out of the schedule to say, I need some help. I'm interested in working in these places and I'm looking for this type of job. Who do you know? And what can you do for me? The other thing that I think is very important, you're already doing right now, you're here at the Rocky Mountain course. Come to these courses. It's another great place for you to hear about employment opportunities and meet some of the faculty throughout the country. So that I don't want to discount how much networking is done at these types of courses. So that's another great thing to do, especially if you're looking for an academic job.
I also spam emailed everyone. Sorry to everyone I spam emailed. I literally took out a map and lists of programs and went down and thought, what I want to go here, what I want to go here, what I want to go here, and emailed the chief of the division, or if I knew a specific attending, like I'd met them in a course or I just knew them from research, et cetera, I emailed them directly, kind of at a template letter, changed it a little bit for each program, and just mass emailed and got a lot more responses about places that are hiring than I did get word of mouth alone, but word of mouth was also helpful.
Yeah, we were very excited to get your email, and fortunately, Wash, you hired you way before we could ring you for an interview, so that was effective as well.
Hi, my name is Bashar. I'm one of the third-year fellows at the University of Connecticut. My question is about the type of practice. For example, if you would start with academic and then you would want to switch to private, or the opposite, maybe if you start private and you decide you want to switch to academic. How easy the transfer is, and what are the challenges from both settings, if anyone had experience with that?
I can start. I think it's much easier to switch from academics into private. I think, especially just speaking sort of locally, the practices in Denver are always looking for people who do interventional, mostly so that they can keep the business. Whether or not they necessarily have the equipment to perform some of the things that are often done at academic centers, that's sort of its own challenge. But I think you will never find trouble leaving academics and going into private practice. There will always be a need for that. I think the other way around can be more challenging, mostly because your skill set may change. You may no longer be doing the things that would be required at an academic setting. You sort of inherently lose touch a little bit with the pace of academics or maybe your contacts in it. I actually initially took my first job for a year at Kaiser in Southern California because when I was looking for a job, I felt that that was the site where I got to do the most interventional, and all the other academic offers I was considering, I was going to be at a satellite site. Ultimately, I came back here, but I think that's a unique situation, right? Because I trained here, so I knew all of them very well. I think it's harder to go into private or a community practice, say like Kaiser, and then move back to an academic institution that's not one you trained at. I think that's a harder switch to make. Is it impossible? No, but I think if you're on the fence, probably the other direction is easier. That's my opinion.
Yeah, you have to also think about what your capabilities are going to be within a certain practice. I mean, in order to do high complexity, high risk cases, get those referrals for patients that require, many of these more advanced procedures. It's not always, but it's gonna be harder to find that community practice. Most centers are looking for somebody to cover, grade one ERCP call and maybe do basic diagnostic US procedures. Doing some of the riskier stuff, you need people who you work shoulder to shoulder with who have more experience and can back you up. You need surgeons that are very specialized and have the capability to support you if you do have a complication. And the tolerance for complications, which do happen, is a bit higher at academic places or places with that kind of support than they are in the community. So, yeah, as you said, your skill set or certain segments of your skill set can atrophy. One example is, very frequently you'll see in community practice people come out from advanced endoscopy programs, but they're doing less and less pancreas work. They're doing less and less of those referrals. You need to be doing that sort of thing all the time in order to take care of those sorts of patients. So that'd be another reason why that transition from community practice to academics could be very challenging. So, there's no hard, fast rule, but, in general, that's something to think about.
Hi, I'm Abdullah. I'm a second year fellow from New York. How realistic is it to find a therapeutic niche or niche in therapeutics without going through the conventional year of advanced endoscopy training?
So how easy, I'm sorry, I'm repeating every question so that everyone else can hear it as well. So how easy is it to find a therapeutic niche without doing a fourth year endoscopy fellowship, right? So I think for interventional endoscopy, ERCP, EUS, stenting, and so on, there is a very set pathway to do this kind of training. So I think for those, I think it is probably desirable to spend that extra time to get the appropriate training. And it's not just doing the cases, it's training to competency. And you're going to hear more about that, tomorrow or day after in one of our lectures. So I think training to competency is the one thing. Getting for doing colonoscopies and EGDs, you can always find a certain area. I mean, GI bleeding, there's a lot of stuff you can be very good at without having to do that extra year. The question is, do you have the training that you're competent at that point to be able to do that? And that's my take on it. So I'm not saying everyone needs to do a fourth year fellowship, but the question is, without doing it, would you be competent to do that kind of procedure?
Okay, I'm going to have a stronger viewpoint on this with regards to training in therapeutic endoscopy. And I'm going to tell you this now because you're a second year and now is the time to make that decision. If you're really interested in therapeutic endoscopy, I would highly recommend that you do a fourth year of training. Mihir just talked about, just going from training to competency or to even mastery. I will tell you that your 3-year fellowship is not going to equip you with adequate training to do EUS and ERCP. That's a no-brainer, and we've shown that consistently in several studies. The number of procedures that you need to get exposed to get the basic level of competency for EUS and ERCP, no general GI fellowship is going to give you that. And if this is a career that you're going to dedicate your life to, I think it's time well spent, whether you decide EUS, ERCP, resection, third space, whatever it is, get trained by experts in this field so that you have the necessary training. I will also say, I think this is something that was brought up earlier with regards to mentorship, finding a job. I think this is such an important aspect. I can't tell you enough or stress enough the importance of having a mentor that is truly invested in your career. So if you have one, that mentor of yours is going to pick up the phone and call places all over in the country to ensure that you get the job that you're looking for. And that mentor should be someone guiding you for your, it may not be the same mentor for your clinical work, research, life. I mean, there's so much literature on having a life coach as well. Highly recommend it. And I think we may be running out of time soon, but if you ask me what are the things that I've learned over these last few years, I think just being more cognizant of personal well-being and really taking the time to ensure that you strike a work-life balance. And it's not balance, I think of it as work-life harmony. And I've seen a shift in my life personally as I've given this importance.
Sachin, if I may be the counterpart of this argument, I think that particularly, I think many of the fellows are interested in endoscopic resection, for example. And I can tell you from my experience, many of my colleagues in private practice and academics who want to focus on endoscopic resection, they are leading a great career in just focusing on endoscopic resection in terms of EMR, ESD, full thickness resection, and even going into third space such as POEM. You could argue, like, why would I need training in ERCP and complicated ERCP and pancreatoscopy and cholangioscopy if all I'm going to be doing is endoscopic resection or third space? But unfortunately, as Sachin mentioned, that we don't have really good programs to train in just these focused areas. But for people who are interested and can find the mentor, we have a precedence here. One of our faculty, Larissa Muthing, actually focused some of her time on learning endoscopic resection, and she's doing fantastic. She doesn't want to do EUS, she doesn't want to do other things. So that's possible. And there are people that I know in private practice where they have multiple members in the group, and they just send all the resection stuff to them, and they're also doing a great job with that. So if that's what you mean, or that's something like that kind of a focus, I think that's doable, particularly if you find a mentor.
Okay,
Time for one more?
I think we need to walk if it's very, very, very quick.
Okay, I can't control that.
The answer has to be quick. I can, it's really quick. I was wondering, is it advantageous to perhaps pursue an advanced endoscopy fellowship maybe 1 or 2 years after graduation? Getting your beak wet, going, as a general gastroenterologist. Is there any thoughts or impressions on that, or should we just super specialize as soon as possible?
I don't think it's necessary. I think if you're not certain about what you want to do and/or your resume or application isn't where you think it'll be competitive, then I can potentially see how that could bolster it if you're doing things like research, gathering new mentors, really doing something to make your application different or figuring out a niche or what you would be interested in. But if you're not doing anything that changes that application and/or you already know you want to go into it, I don't think any program necessarily views that extra experience at that point as super helpful or beneficial to your application. Okay, thank you, everyone. This has been a great session. Thank you also to our IT, AV, Christy, Michelle, Matt. Thank you all. They are going to walk you over now to the Endo Lab, and we will see you guys there.
And can I just make one quick comment? Your hands-on assignment is in your badge. So if you just look at your badge, you'll find your assignment. Thank you.